So today's talk is on nutritional disorders on the elderly, but it's also blending with nutrition. Uh, we have a small group, so I would like to make this as interactive as possible. Okay, some of you have seen certain aspects of this talk before, but repetition is a great tool in learning, so it's a good review for some of us. This is one of my favorite slides. I have it in every one of my presentations, and for me, it's a reminder of the various environments, the various places in which we find older adults. And we can find them, yes, we can find some older adults in the critical care setting, in the hospital, but we also can find older adults in normal settings, in healthy settings across the world, whether it's in casinos or churches or in the parks or cruises prior to the COVID pandemic, right? But they're everywhere. Okay, so it's a great and in terms of health, a comment on their health, older adults can and do live normal, healthy lives. So I have no significant financial disclosures or conflicts of interest. However, certain aspects of this talk is supported by a grant from the Health Resources and Services Administration of the United States Department of Health and Human Services. Um, in addition to that, a lot of our presentations and a lot of our talks will be combined into a broader geriatric curriculum, self-learning modules, right? And that will be available for all of us to review independently at our own time and pace. So what's the objective? Some of the objectives for this talk is one, to define geriatric syndrome, two, to define dysphagia and identify factors contributing to dysphagia, three, to describe the specific geriatric syndromes of malnutrition, right? Meaning undernutrition and overnutrition or obesity. And finally, to identify the diagnostic and therapeutic approaches to the management of undernutrition and obesity. Okay, this is an important slide because it reminds us that there are many age-related changes in the human body. Okay, as we get older, there are visible signs of aging, right? What are some of the things that we see uh, visually? We see on an older adult as they age, certain changes when compared to the younger page, the younger adult or the younger person. What are some of the changes that we might see? Anybody?
Receding hairline in men and women,
Receding hairline. Oh,
males and females.
yes, that's possible. Also, thinning of the hair. Anything else? Discoloration or loss in the pigmentation of the hair.
Poor dentition.
Poor dentition, possibly, yes, that we see. Uh-huh. What about the skin? The skin becomes thin, right? And that,
Thinner, yeah.
yeah, because it can, the skin becomes thin, and so the connective tissue or the subcutaneous tissue, there are changes there. And that can predispose or put the older adult at a higher risk for skin tears, right? Sometimes, the force that we may apply to the younger adult's skin, it may be okay, but we apply that same, degree of force to the older adult and it results in a skin tear. So there are changes that have clinical implications, right? There's also a decrease in the amount of lean body mass or the muscle mass, right? Sarcopenia, we call it, right? But in addition to some of the external changes or the visible changes, there are also internal changes, right? What have we noticed about the fat distribution of a younger person to the older person? So I was and this is a true story. Like 2 nights ago, I was smiling with my wife. We were just talking, and um, I said, I'm pretty much the same weight that I was when we got married 18 years ago, right? I'm pretty much like a 5 pounds difference, but I'm pretty much the same weight. And she says, yes, you were the same weight, but the distribution is different. So there is usually, as we age, there may be a shift from, muscle mass to an increase in the body fat content, right? And along with that, there's a change in what I call the volume of distribution, where things go. For example, where fluids go, where medications go. There's also a change in the kidney function, the renal function. Specifically, there may be a decrease in the creatinine clearance, the ability of the kidneys to clear out certain things, right? And all of that has clinical implications because it affects how it can affect how we would prescribe, let's say, for example, medications. It would affect the dosage. We have to adjust for the dosage. We have to adjust for the frequency and things like that. In addition to changes in the volume of distribution, uh, there may be changes in terms of how the older adult perceives food in terms of the taste. Now, what do I mean when I say there's a decrease in taste sensation, but there's not a decrease in the ability to discriminate? What do I mean by that in terms of food? Anyone? So, in an older adult, right, the older adult maintains the ability, a normal, healthy, aging adult, older adult maintains the ability to taste and to discriminate between, let's say, sweet and salty. Okay, they do not lose that ability. So there's not necessarily a change in the ability to discriminate in terms of the taste of food. However, the older adult, in order to detect saltiness, may need a higher concentration of salt to detect it, right? So there's preservation in the ability to discriminate between the different flavors of food, the different tastes in food, but they may need a higher concentration to recognize that. But all this stuff is important again because some of the standardized nutrient requirements and medication prescribing guidelines that we use for older adults, that we use for younger adults, cannot and should not be generalized to older adults. Okay, so here's a question. This is a question that sort of meets out a lot of important things. Um, it's a it's a case. It's taken directly from the GRS, the Geriatric Review Syllabus, and it's a case of an 81-year-old female. She status post surgery for a ruptured appendix about a week ago. According to the chart, she responded well to IV fluids and antibiotics, so she's doing well, and she's been afebrile for 4 days since her surgery. A review of the nurse's notes shows that she is on a regular diet, but the patient consumes between 50% and 75% of her meals. That's what the nurse's note says. Her past medical history is unremarkable. There are no other underlying medical problems. Okay. On physical exam, she's alert and oriented, the person, place, and time. She's not in any acute distress. Her weight is 175 pounds. She's about 11 pounds more compared to her weight at admission. So she gained about 11 pounds. She's still in the hospital. This is 6 days after surgery. Okay. Her BMI, body mass index, is 28. Her lungs are clear. There's no distension of the neck veins, right? We have medical residents here. We have fellows here. What would a distension of the neck vein tell us? If her jugular vein was distended, what would that tell us? So her jugular vein venous pressure is less than. Go ahead. I'm sorry.
Yeah, so it could be a few things. Maybe a patient has volume overload, like CHF.
Right.
If after a surgery, depending what surgery, could be, cardiac tamponade, which could cause jugular vein distension also.
So excellent, right? Excellent, excellent. So it's a commentary on the volume status to some degree, and it's a commentary on the cardiac function, right? But on physical exam, as we proceed, she has 3 to 4 plus pretibial edema and presacral edema, and that edema, that fluid retention, was not present on admission. Her surgical wound is clean. Okay, it's normal, it's clear. No erythema, no discharge or anything like that. Her labs, significant for everything is normal. Electrolytes are good. There's no evidence of kidney, issues, no acute renal failure. Her BN creatinine is good, and her white count is normal. There's no leukocytosis. Now here's the question, and this is a classic. This is a classic board question. Okay, which one of the following would be most helpful for assessing the adequacy of this patient's nutritional intake? So the question is that we're trying to gauge whether or not this patient is eating adequately or consuming adequately. So A, serum albumin level, B, serum prealbumin level, C, daily weights, D, resting metabolic rate measured by indirect calorimetry, and E, complete calorie count for the next 3 days. So which is the best assessment of this patient's intake? Anyone?
Okay, so I would go with serum albumin level.
I would go with E.
What's the
Complete
second comment?
I would go with complete calorie content, calorie count. I don't think albumin is used as much for nutrition as a measure anymore. I could be wrong. We'll see.
So we have two answers. I wish we could do a poll. This is a classic, example of when a poll is indicated to get a poll of the audience's responses. So we have one answer saying serum albumin, and a second answer says complete calorie count. Okay. Any other takers? Any other?
I would just comment and think that the caloric intake count wouldn't be enough because you don't know what the patient is absorbing from those calories.
Okay. I hear your point. So you're commenting, you're taking it a step further. Intake is one issue, but you're taking it a step forward and saying, irrespective of what's being eaten or taken in, what percentage of that or what proportion of that is being absorbed? That's a great point. Okay. But for the purposes of this question, there's one best answer. Okay. Does anyone believe that B, serum prealbumin, is the correct answer? No. How about daily
We do
weight?
have a answer from Sam Jackson, Dr. Prospere,
Oh, I'm
and
sorry, I
he
can't see the chat.
suggested the
I was
serum
just I was just
albumin.
agreeing with the serum albumin. I think.
Okay, so you disagreeing or you agreeing?
Agree with A.
Okay, so there's agreement at A. No one for prealbumin. Anyone for daily weights? Am I setting you guys up? How about arresting metabolic rate measured by indirect I cannot pronounce that word today. So the correct answer is E, right? Now, what's the best way to assess or to gauge the patient's nutritional intake? Well, the plate or the food is delivered to the patient, and the best, most objective way to know how much the patient eats is to observe the patient eating and see what remains on the plate, right? So the correct answer is complete caloric count for the next 3 days. Okay?
I wonder if what she's eating in the hospital, I wonder if that's really what her nutrition is. And a calorie count isn't going to tell us much about her nutrition. It'll tell us about how many calories she consumes. It's easy to consume calories with 3 candy bars, which won't help her nutritional status any. So I don't like any of those answers.
Absolutely, Dr. Gerard. Absolutely, you're correct. However, the assumption is that there is some control on the patient's diet while hospitalized, right? So the assumption is that we know what the patient is being fed while they're hospitalized, right? In terms of breakfast, lunch, and or dinner. So we know the meals that's being delivered to the patient. Um, Serum albumin is not used much, and there are issues with measuring serum albumin, and there are issues with the life of serum albumin. It's just too short. So there's difficulty in measuring it and whether or not it truly reflects caloric intake. Remember, albumin, what is albumin? Albumin is produced, right? So it would be a reflection of synthetic function in the body. So that's more of an indirect mechanism. And the same thing with prealbumin and the other choices. It's more indirect. So the best answer though is E, actually observing what the patient is being fed. Okay, what's delivered to the patient and what the patient is being fed. And Dr. Gerard is correct, right? Is it an assessment of our nutritional intake, assuming we know the content of the meal? Okay. Here's another question, and this question brings to light a lot of issues, and it combines a lot of the different problems that we can encounter in an older adult. A 74-year-old female, she's a widow. She has a past medical history significant for hypertension, borderline diabetes type 2, osteoarthritis, degenerative arthritis with pains in the knees. She presents to her primary care physician for a routine checkup 11 months after the death of her husband. She lives alone and gets 2 to 3 visits per week from her children and members of her local church. The patient reports a 2-year history of bilateral both knee pain without associated knee joint swelling, redness, or warmth. She also reports numbness in her hands and feet and 16 pounds weight loss. 16 pounds weight gain in the past 6 months. She laughs appropriately in response to your joke. On physical exam, her affect is appropriate and her mood is good. She is 5 feet 2 inches tall and weighs 203 pounds, which correlates to a BMI of 37 kilograms per meter squared. She uses a rollator with seat to ambulate. It's a lot of information. Okay? Her history and physical exam is associated with which of the following? Okay? I'm going to ask you to retain your answer, and we're going to discuss this in the end. Okay? Select your answer, retain it, and we'll discuss it in the end. Okay? Her history and physical exam is associated with which of the following? 1, increased risk of functional decline. 2, increased use of healthcare resources. 3, increased risk of dying. D, poor diet quality and micronutrient deficiency. Or finally, all of the above. Okay, so keep that in mind. So just a quick review, what is a geriatric syndrome? So a geriatric syndrome is a group of signs and or symptoms that tend to occur in older adults more frequently than they occur in the younger adult. And these signs or symptoms, they characterize a particular abnormality or condition in such a way that they happen more frequently than is likely due to chance alone. When we speak of signs and or symptoms, keep in mind that this also includes emotions and actions, okay? Again, these emotions and actions, these signs or symptoms, they form an identifiable pattern. So these are some of the geriatric syndromes that are part of our geriatric curriculum. The ones in yellow are some of the ones that I present on. We have a group of excellent lecturers that give talks on some of the other ones and other topics also. Today, I'm going to touch on the ones in red: nutrition and weight, malnutrition in parentheses, dysphagia, and obesity. So why is this relevant? This is important. One reason is our population is aging. Okay? The percentage or the proportion of older adults in the population is aging. Okay? In addition to that, though, this is relevant because we practice evidence-based medicine. Okay? And by evidence-based medicine, whatever we do, our assessments and our intervention should be geared towards improving quality of life and life expectancy. Okay? And I'm saying that in the context of whatever we do also should be guided by the age-friendly model or the 4Ms framework. Okay, so our assessments and interventions should take into consideration the 4Ms, meaning 1, what matters to the patient, should take into account the patient's functional status and mobility, the medication regimen, and mentation, right? So our goals of care should be aligned with, the patient's choices and the patient's best wishes, what matters to the patient. Another reason why this is important is because we believe that early detection or identifying problems early can translate into better health outcomes or improved health outcomes. So, nutritional syndromes. Let's brainstorm for a minute. What is malnutrition? What do we think the definition of malnutrition is? Anyone? Mal? What is mal? Mal, maybe bad nutrition. So, in order to answer this question, I think it's important for us to understand, or at least to comment on what nutrition is in the first place, right? So, what is nutrition? Nutrition is food, okay? It's nourishment, okay? It's the process of providing or obtaining the food that is necessary for health and for growth, right? It is recommended that, in terms of nutrition, it is recommended that we all eat a balanced diet, okay? And in the context of an older adult, yes, it's recommended that the older adult eats a balanced diet. So what do I mean by a balanced diet? A balanced diet is a diet that consists of the proper proportions of, the different food groups: carbs, fats, proteins, vitamins and minerals, and so on. And of course, don't overlook fluid intake, right? And the proper proportions that is necessary to promote and to maintain good health. So there are nutritional requirements for the older adult's body. And the nutritional requirements are necessary in order to, again, sustain life, one, and two, to promote good health. The nutritional requirements are broken down into three groups. I say three groups. It's broken down into macronutrients, right? It's also broken down into micronutrients, and it's also broken down into fluids. I'm putting fluids there because we often overlook fluids, but fluids are an important part of our intake, right? Micronutrients are divided into vitamins and minerals. Does anyone know what the image on the right is?
My healthy plate.
Yes. I think Dr. Lawrence, Carly Lawrence, does an excellent talk, and she gets into this kind of stuff. Dr. Lawrence, can you comment on my plate, please? Would you mind? I'm sorry, I'm putting you on the spot. You're muted, Dr. Lawrence.
Thank you. Yes, my plate for older adults. So this is replacing the food guide pyramid that we all grew up with, the many different pyramids. I'm really glad they came out with one for older adults, because this does address what you're speaking about, the changes, the physiological change that happen as we get older. As you can see, the biggest thing on here is that it's more evenly divided. It's like almost in quarters versus the regular My Plate. If you've seen the new My Plate that's out there. So we are advising our older adults to have a more balanced meal throughout the day, instead of having, different, like more fats here or more carbohydrates. It's a balanced meal throughout the day. That's what I got from this, and why I like this picture so much.
Thank you so much. Thank you.
No problem.
One other thing I like about it, and what Dr. Lawrence said is correct. So it is a modified food guide pyramid, and it tells you, it kind of outlines the different proportions of each food group that is recommended that the older adult should take. So it's broken down into the amount of fats, carbs, protein, fiber, and so on. Now, this is available online. We can find it. I'll show the website later, I believe. But what I like about this is that it has recommendations that are culturally sensitive, and that's a good thing, because it's important to think about the different foods that different cultures prefer to eat. Okay. This is a list of some of the micronutrients that are important to us. And when I say it's important, I'm thinking of it from the context that too much, right? Too much will lead to excess or toxicity, which can lead to disease, right? And too little is a deficiency, and that too can cause problems. For example, let's pick calcium. The first one is calcium. Can too much calcium be dangerous?
Yes.
Yes, right? And can we, what kind of problems can we see with calcium? Anyone? Anyone?
Hyperparathyroidism.
The stones, bones, thrown, psychiatric overtone.
Say that again?
I think of the stones, bones,
Yes.
thrown, psychiatric overtones. So
Okay, absolutely. Thank you. Thank you. I want to make sure the images that I'm not boring everyone, and the images that I'm just seeing names, that you're not falling asleep on me. What about magnesium? Can hypomagnesemia, low magnesium, cause any problems? What's the problem that can cause by low magnesium? A deficiency in magnesium. It's on the boards. It's juicy on the boards. I'll give you a big hint. An EKG abnormality.
arrhythmia,
Arrhythmia.
prolonged QTC, yeah, like
Absolutely.
torsades.
Torsades, right? That's a board question.
Mhm.
Let's jump down to two more. What about niacin? Do you guys remember niacin? Can niacin deficiency cause problems? I remember in medical school reading about a certain culture where they only ate corn. The primary staple was corn, right? And so in corn, there's a deficiency of, if that's the primary staple in your
The
diet.
pellagra,
Ah, absolutely. What is that though? That's a big word. What is pellagra?
I just remember skin manifestations. I don't
Mhm.
actually remember much about
Yeah,
pellagra.
but thank you. It is pellagra. It's the D's, right? The three D's. Dermatitis, right? D,
Mhm.
dermatitis. The other D is GI, diarrhea, right? Remember
Dementia.
that the lining of the GI is also a skin, right? Think of it as a skin. The lining of the GI tract is kind of like the skin. So you get dermatitis on the skin. In the GI tract, you get diarrhea. And then, of course, it can affect the brain, right? So dementia, right? Okay. So, and the last one, which we tend to see a lot, and I don't want to overlook it, is there, do we notice vitamin B12 deficiency in older adults? So these are all micronutrients, right? And there's a
Yeah.
daily recommended dosage in terms of micronutrient intake. Do we see vitamin B12 problems in older adults?
Yes.
Yes, and so what kind of problems? How do those patients? Some of them present clinically. What kind of problems can we see in an older adult? Anyone?
It could be dementia,
Yeah,
gait abnormalities. Um,
absolutely.
Anemia.
Absolutely, right? And so a significant fraction of patients, I check B12 level on all my patients annually. And, in truth and in fact, they can present anyway with any kind of sign or symptoms. A lot of patients present with dizziness, some degree of cognitive impairment, forgetfulness, right? So yes, and sometimes gait abnormality. The classic finding, which I haven't seen, but subacute combined degeneration is part of the sequelae of vitamin B12 deficiency. Okay, this is an important slide. It reminds us that age-related changes impact energy expenditure, right? Age-related changes impacts energy requirements and expenditure, right? This is important because it can affect how much we eat or how little we eat. So now the basal metabolic rate, BMR, right? The basal metabolic rate or the resting energy expenditure, okay, it is the principal determinant of health. It is the principal determinant of energy expenditure. And we have to remember that. The basal metabolic rate, okay, and this can explain why a lot of individuals, not just older adults, but other individuals sometimes have difficulty gaining weight or losing weight, right? So, irrespective of the intake, and I'll put that in quotes. But the basal metabolic rate or resting energy expenditure is the principal determinant of total energy expenditure. So, the amount of energy we burn, the amount of calories we burn is primarily dependent on the basal metabolic rate. Okay? Now, a decline or a reduction in the basal metabolic rate is a reflection of our lean body mass. So if there's a decline in the basal metabolic rate, it may indicate that there's a decrease in the lean body mass, or as we get older, sometimes sarcopenia. Okay, so loss of skeletal muscle. Now, this is the second part of what I wanted to emphasize. Energy expenditure, the burning of calories, energy expenditure related to physical activity is variable, right? The principal determinant of energy expenditure is the basal metabolic rate, and not so much physical activity, although physical activity plays a major role. Okay? So, in determination of energy needs, care must be taken. We must pay attention. Care must be taken to avoid overfeeding, right, while meeting basal energy requirements. Okay. Nutritional intake, they're macronutrients, right, such as the carbohydrates, the proteins, the fats, and so on. They're micronutrients, we just mentioned, the vitamins, the minerals, right, the vitamin D, thiamine, and so on. But there's also fluids. Fluids are important. In normal healthy aging, there may be a decrease in the older adult's ability to sense or to perceive thirst, right? So there's a decrease in the perception of thirst. That's important. Also, there is an impairment in the body's ability to respond to serum osmolality. What is serum osmolality? The concentration of sodium in the blood. Okay? And finally, there's a reduce in the body's ability to concentrate urine. And that's all part of normal healthy aging. In the disease state, right, there may be a decrease in mental or physical ability to recognize and or express thirst. So for example, someone who suffered from a stroke, or someone who has an underlying dementia, may not be able to sense that they're thirsty, or if they're aware, may not be able to communicate that they're thirsty, and therefore may not be able to indicate that they need water, right? Similarly, someone with a neuropsychiatric illness may also have an issue with accessing fluids or accessing water, okay? It is recommended to drink a lot of water every day. Caution in the setting of underlying heart disease, caution in the setting of kidney disease, right? So the pumping function in the body, congestive heart failure, for example, care must be taken when taking fluid in. Also in individuals with decreased creatinine clearance or chronic kidney disease, care must be taken in terms of how much fluid, he or she drinks. So the recommended is 30 ml per kilogram per day. What is that? So approximately 8 cups per day. How many of us actually drink 8 cups per day? That's an important question. So remind me to drink some water. So keep that in mind, okay? We should hydrate. It's an important part of our intake. Now, in the older adult, there are issues, as I mentioned, with sensing thirst. There's an issue with regulating or concentrating the urine, and there are issues with and this is normal healthy aging. There are issues with responding to changes in the serum osmolality. In addition, some older adults may not be able to mount an immune response. That could be an issue. Or we have to factor in fevers and other conditions that would result in insensible loss of fluid, right? And all those things can lead to a major condition. What is the most common fluid and electrolyte abnormality in the older adult? Especially in the summertime. Yes, Dr. Gerard?
Dehydration.
Dehydration. Dehydration. It is the most common, okay? It is the most common fluid and electrolyte abnormality in older adults, right? How do patients, or how do individuals, older adults with, let's say dehydration, and this is more of a clinical question, but how would a patient like that present? Well, obviously it depends on the degree of dehydration, right? But how can a patient with dehydration present to you? An older adult?
Confusion.
Confusion?
Weak, dizzy.
Weakness, dizziness. Can I hear from some of the students, please? Weakness, dizzy. Why is the patient dizzy?
Due to hypovolemia.
Hypovolemia, low fluid. They lost fluid somehow. They didn't drink adequate. The body used some of it. They eliminated some of it. Okay, so low volume. Low volume drops the pressure. Low blood pressure leads to decreased perfusion to the brain, decreased blood flow to the brain. Decreased blood flow to the brain is manifested as dizziness. If the pressure is low enough, the patient may syncopize, right? How
Maybe
do
confusion.
confusion? Yes, absolutely. Thank you. On physical exam, how can we tell that a patient is dehydrated?
Dry mucous membranes.
Absolutely, dry mucous membranes. That's true. We can agree on that. That's correct. Except sometimes it's not so obvious, right? But that's correct. Any other reason? Any other ways we can assess dehydration or hypovolemia?
Decreased capillary refill.
Absolutely. But any other direct way? Anything we do every day on patients every time they present?
Maybe they're tacky.
Tachycardia, so the heart rate and the pulse, right?
The skin turgor.
Skin turgor. You guys are missing one of the most simple ways of assessing. Come on, you have it there. You do it every day. You ask it all the time. It's an important part of the assessment.
Maybe just ask.
Pardon?
Maybe we can just ask.
Maybe what is that?
Just ask the question.
How do we assess?
No,
No,
he's
no, no.
saying just ask the patient the question, like, are you taking in enough fluid?
Oh, I'm sorry. Yeah, that's true. The patient may not be aware that they're taking it, but yes, that is true. Ask the patient specifically, how many glasses do you drink, if any? How much do you drink? How many bottles? So that's a correct point. Thank you. The history on the physical exam.
Low blood pressure?
Thank you. Thank you so much. Who said that? Who said that?
Hermione.
Thank you so much. It is
she had put it in the chat before.
Oh, I'm sorry, I can't see the chat. So they're called vital signs, right? Very important signs. They're vital. So the blood pressure, yes, that's important. Blood pressure, someone said tachycardia, so blood pressure, heart rate, okay, and even in certain situations, the respiratory rate, right? Why would the respiratory rate be high in someone who is dehydrated? Acid-base physiology.
They're acidotic and trying to blow off carbon dioxide to compensate.
Absolutely, that's a board question, I think. Okay, now one more clinical question. A patient who you suspect dehydration, okay, and the patient is resting in bed, lying in bed. You suspect dehydration. The urine. What does the urine look like?
Dark and concentrated.
It's very concentrated, right? Okay, and there are reasons for that. So now the patient is in bed, you suspect dehydration, and the blood pressure is normal, seemingly normal. It's 120/75. Are we happy with that? Is there anything else I need to do? Am I contented with a supine blood pressure of 120/75 in a patient, an older patient with dry mucous membranes and concentrated urine, and maybe a heart rate?
Check orthostatics.
Yeah, the heart rate is 98, dry mucous membrane, concentrated urine, dizziness. Yeah, you're right. Do orthostatics, okay? Very important. Don't be fooled by a seemingly normal blood pressure. Okay, so yes, dehydration is the most common fluid and electrolyte disturbance in older adults, okay? And you guys mentioned most of these things. Someone mentioned confusion. So there's tiredness, sunken eyes, dry mucous membrane, dry skin, tachycardia, even constipation, okay? Now, abnormal nutritional intake. So what's abnormal nutritional intake? So malnutrition. It spans the spectrum of either undernutrition it ranges from undernutrition to overnutrition, right? And again, age-related changes in physiology, metabolism, and function can change. It can alter the older adult's nutritional requirements, okay? And that leads to malnutrition. How do we measure nutritional status? A lot of it is indirect. Okay, a lot of it is indirect. Again, we commented early on actually physically observing how much the patient actually eats. So the patient is served, and then we observe how much the patient actually ingests. But in addition to that, someone made a comment that yes, you know, eating calories does not necessarily comment on nutrition, and that's a great point. In addition to that, someone else made a comment earlier that even though a patient is ingesting, it doesn't necessarily mean that the patient it's being absorbed in the GI system, right? So keep those things in mind, those points in mind. So how do we measure nutritional status? The term anthropometric is used, and it's an indirect way of measuring nutritional status. Anthropometric is the study of the measurements or the size and proportions of the human body. We usually just say BMI. What's the BMI? Okay. So the BMI is measured by dividing the BMI is measured by dividing the weight in kilograms by the height in meters squared. Okay. So what is normal BMI? Okay. What is normal BMI? Normal BMI is usually somewhere between 18.5 and 25. Okay. Now, so can someone explain to me if the BMI is above 25, what's the cutoff? And then we have to be sensitive to certain should I say ethnicities or certain races, because the distribution and the proportions is also important when we consider in BMI, right? But what about a BMI above 25? Are there any specific thresholds that indicate certain conditions? Can someone comment on that? So, for example, a BMI between 25 and 30, what's that considered?
It's overweight.
It's considered overweight. And then a BMI above 30, by definition, is considered obese, right? I have to review what the correct term is now, because I believe the terms are changing in terms of what's acceptable, whether it's okay to say obese now versus excess weight. Okay, so keep that in mind. Let's get that and verify it. In terms of inadequate, so that was overnutrition, BMI above 30, obesity or excess weight. So there's undernutrition also. Okay, and undernutrition is defined as an average intake or average nutritional intake of food groups, nutrients, or energy 25 to 50% below a threshold of the recommended dietary intake. So it's the average intake of foods, nutrients, or energy that is 25 to 50% below a threshold level of the recommended dietary intake. Okay. In terms of the prevalence of undernutrition, as much as 13% of older adults, outpatients, are considered are undernourished. Okay. As much as 25 to 50% of hospitalized older adults are undernourished, and as much as 50% of skilled nursing facility residents. Okay, now a BMI that's less than, and I know I said earlier 18.5 to 25 is normal, but a BMI of 17 or less, okay, is indicative of an individual who's chronically undernourished. Okay, an individual who is chronically undernourished. Now, a BMI of less than 17 is also associated with increased morbidity and mortality. Energy intake that is less than 50% of the basal metabolic rate requirements is associated with higher rate of dying, okay, than energy intake that's above the BMR requirement. And it's important for us to keep in mind that the lack of access to food commonly contributes to undernutrition, lack of access, right? So limitations in resources, limitations in functional ability, right? If a patient, for example, cannot exit the bed, cannot transfer from the bed and get to the kitchen or get to the refrigerator, right? Even though food may be present in the refrigerator, that can lead to, it can be considered lack of access, and it can lead to undernutrition. Issues with transportation, okay? And issues with limitations in preparation of food. Even issues with, someone mentioned dentition earlier, so poor dentition. So even though the food is available, issues with chewing and ingesting can lead to undernutrition. So poor intake is often an indication of illness. Unintended weight loss. Unintended weight loss of 10 pounds or 5% of the usual body weight in a 6 to 12 month period is an indicator of underlying disease. Okay, undernutrition and poor intake with associated weight loss is a predictor of functional decline. It correlates with healthcare expenditure, and it also correlates with increased rate of hospitalizations. Okay, undernutrition leads to unintended weight loss. Undernutrition also leads to micronutrient deficiency and vitamin deficiencies. And so some of the problems that we mentioned earlier with the vitamin deficiencies, maybe pellagra or B12 deficiency and other things can happen. Undernutrition and weight loss and all the sequelae of that and vitamin deficiency can lead to poor memory. It can lead to increased risk of infections. Also, it's associated with poor wound healing. So increased risk of maybe pressure ulcer formation and poor wound healing. And finally, it's associated with an increased risk of mortality, dying, right? So how do we treat undernutrition? Well, if the issue is lack of access, then we provide access, right? If the issue is poor quality, then provide a good quality, a balanced diet, or a diet that's rich in whatever the patient is deficient in. So in terms of treatment, education and prevention is first line, okay? In addition to that, again, we provide access. Title 3C of the Older Americans Act Nutrition Services Program, it provides for congregate and home delivered meals for older adults, irrespective of their financial or economic status. Okay, and a comment on that: it is believed that, well, adequate access to nutritious and appetizing food should be assured for every older adult. Okay, irrespective of their cultural background, irrespective of their status. I don't know if the programs like this are available everywhere, though. I don't know if Shirley has a comment on that. I don't know if you do.
Which program do you mean? There's a number of them in Brooklyn.
So I don't know. So maybe in Brooklyn, yes, but I don't know how easy it is to provide access to food in individuals who are more maybe in rural areas or, you know, so older adults. I don't know if they have access to food or a program that would support them.
It's a problem. It's a problem everywhere, even in Brooklyn, especially during the pandemic, because there's been so much demand. And one of the problems is even when there's adequate food, it's getting people linked up to the service because people are at home and no one connects them. And there are, the senior centers are wonderful about helping people to get linked up to services. There's also at the Borough Town Hall or City Hall or whatever it's called, Borough Hall. There are also resources there that are available to help people that are really excellent. So it's not as hard, I don't think, in Brooklyn as in many places. Rural areas are hard just because of transportation. But it's home delivery that's really makes all the difference, especially for older adults and especially during the pandemic. And the agencies that distribute food have adjusted pretty well to that.
Thank you, Dr. Gerard. So, and then it's important to keep in mind also that if you wanna increase the likelihood of an older adult eating, then it's good to provide quality food that tastes good. You know, you want to provide food that tastes good, food that looks good, food that smells good, right? So it cater to the food preferences, pay attention to the color, the consistency, and so on. Even the temperature, right? Certain foods don't really go down well if it's too hot or if it's too cold. Okay, and the setting is important, right? Eating together may increase the likelihood of someone being willing to eat. In terms of treatment of undernutrition, uh, this is important in terms of treatment of many conditions. Address the underlying issue. If there's a medical issue, address, target that underlying issue, correct the underlying medical problem. Okay, so if it's an issue with poor dentition, whatever it may be, address, oral care may be important. Okay, so provide appropriate mouth and hand care where indicated. Okay, be careful with therapeutic diets. Okay, be careful with therapeutic diets. Vet diets to verify that they are evidence-based. Okay, there are a lot of diets out there, but they may not be evidence-based. Okay, so be careful with therapeutic diets. Okay, so the recommendation for the treatment of undernutrition again is to increase caloric intake, a balanced diet with the adequate amount and proportion of the various food groups, including the macronutrients, the micronutrients, and fluids is important. Nutritional supplements is also important, but just be careful that the supplements don't replace the actual meals, right? So, for example, we may prescribe for some patients, let's say, Ensure with the meal. Um, Patients, for whatever reason, may resort to just drinking the Ensure as the meal and not actually eating any other meal. So just be careful that the supplement does not replace the meal. Okay. Um, so high caloric density, lactose-free and gluten-free diets are recommended. There's some correlation. It's small, but consistent weight gain in older adults who eat high caloric meals. Okay. And there's no real evidence to support supplementation of let's say vitamins in an individual who doesn't have a vitamin deficiency. Like there's no real benefit. If you're not vitamin deficient, then there's no evidence showing any benefit um, in terms of giving extra vitamins and minerals. Um, in terms of treatment of undernutrition, there are some medications, but we have to be careful again that we're using an evidence-based approach because our intervention can also be harmful. What we prescribe, there may be consequences or adverse reactions to it. Okay, so care must be taken to use an evidence-based approach, and it should be tailored to the specific individual, to each individual. So, for example, cyproheptadine is sometimes prescribed in the older adult, but keep in mind that it's associated with an increased risk of altered mental status, an increased risk of confusion in the older adult. And Megace or Megestrol is notorious for increasing your risk of blood clots. So again, care must be taken and, not to use some of these appetite stimulants, right? Because of the potential side effects. So let's transition briefly to obesity. Obesity is defined as a BMI greater than 30, 30 kilograms per meter squared. BMI greater than 35 is associated with an increased risk of functional decline in older adults. Okay, so we're getting into the severe category of severe obesity. If the BMI is greater than 35, it's associated with an increased risk of functional decline. Someone has a question? Do I see a hand? No. Also, Okay, a BMI of 35. Keep in mind, poor diet quality and micronutrient deficiencies are relatively common in older adults, especially older adults living alone. Okay, and excess body weight and modest weight gain in the middle age. So what we do in the younger age impacts us as we get older, right? So excess body weight and modest weight gain in middle age may be associated with certain medical problems. So obesity is associated with an increased risk of diabetes. We all know that, right? The mechanism of action in type 2 diabetes is insulin resistance, right? It's associated, obesity is associated with an increased risk of insulin resistance. It's associated with an increased risk of hypertension and other cardiovascular disease, right? Uh, Obstructive sleep apnea and osteodegenerative arthritis. So excess body weight is also associated with, particularly a BMI above 35, is associated with impaired functional status, okay, increased utilization of healthcare resources, and increased risk of mortality. So how do we treat obesity? Again, education, and it's helpful when the instructions is coming from a healthcare provider, right? The rate of compliance is greater, relatively speaking. Okay, so education. Yes, Dr. Gerard?
I just have a question about whether or not bypass surgery is used at all in older adults. I've never seen it used for older adults.
It's interesting. I don't have any examples, specifically in my patients, where we have used bypass or lap band or anything like that in the older adults. Not in any of my patients that I care for over 18 years.
Yeah, I haven't seen it, but
and there I've cleared. When I say clear, I mean in terms of pre-op risk assessment. I've cleared many younger patients for these gastric bypass or procedures, but not older adult patients. And part of it has to do with possibly underlying underlying medical problems that they may have, and the willingness of the surgeon, let's say, to operate on an older adult. So education and encouragement is very important. Counseling by a healthcare provider. In addition to that, if the underlying problem is obesity or excess nutritional intake, again, a reduced calorie balanced diet is indicated. In addition to diet, increased physical activity is recommended. Okay. How do we, like, what kind of advice do we give to an older adult? Like, what kind of exercises do we recommend that they do? Should they go to the gym and pump iron for like 2 hours every day? What do we recommend for an older adult?
well, they could if they were in great shape.
Right.
Like low impact exercises?
Okay. I'll put low in quotes, right? I'll put low in quotes, but yes. So what do you want to recommend? Anyone? Low impact exercises, yes.
30 minutes for at least, 3 times, 5 to 5 times a week.
Yeah, doing what? Doing what?
Of cardio, at least walking.
Walking, right?
Yeah.
But is it limited to walking? Come on, what else can we tell you? So the patient is coming to you, what can you tell them? Is dancing a good option?
Yeah.
You dance? Yeah, right? Increase physical activity, anything to stay active, right? Walking, I agree with you 100%. Walking, dancing,
Aerobics, swimming,
right? So anything to
yoga.
stay active, right? Absolutely. And then the muscle strengthening exercise or physical activity is also helpful. Okay. So let's go back to the original question that we had. One of the original questions from the beginning. So we have a 74-year-old female with a history of hypertension, so high blood pressure, diabetes type 2, insulin resistant, right? And osteoarthritis with pain in the knees. The patient presents to her primary care doctor for a routine checkup 11 months after her husband's death. She lives alone and she gets 2 to 3 visits per week from her children and members of her local church. She reports a 2-year history of knee pain, both knees, without associated joint swelling, redness, or warmth. She also reports numbness in her hands and feet, and 16-pound weight gain in the past 6 months. She laughs appropriately in response to your joke. On physical exam, her mood is appropriate. Her affect is appropriate. Her mood is good. She's 5'2", 203 pounds. Her BMI is 37. She chooses a rollator with seat, okay, to walk. Her history and physical is associated with which of the following? A, increased risk of functional decline. B, increased use of healthcare resources. C, increased mortality. D, poor diet quality and micronutrient deficiency. And E, all of the above. Okay. Let's go through this case one by one, item by item. She's 74, so she's an older adult. Hypertension. Is hypertension associated with obesity? Does nutrition impact hypertension?
Yes.
Yes, absolutely. Remember the topic of today's discussion, right? Nutrition in the elderly, right? So hypertension, nutrition can affect hypertension. Can nutrition affect diabetes?
Yes.
Yes. And can anything, what in our history points towards can increase our risk of knee pain or worsening knee pain? What in our history can do that?
Numbness, apathy.
Pardon? Okay, what on a physical?
Osteoarthritis.
Absolutely. So osteoarthritis, okay. So that's by definition. What do we make of? I'm jumping the gun. What do we make in the context of osteoarthritis? What do we make of the fact that she does not have joint swelling? She does not have redness or warmth. What does that point us away from?
RA.
Or any kind of inflammatory arthropathy, right? So rheumatoid arthritis or any inflammatory arthropathy. What about the numbness in her hands and feet?
B12 deficiency.
Absolutely, right? So micronutrient deficiency, okay? And then, so we can't dismiss the fact that she lives alone and that her husband died about 11 months ago. However, what on our history and physical points away from abnormal grief? Anything in our history or physical that points away from abnormal grief? That makes it less likely? How is her mood? How is her affect?
She reports it as good.
Okay. So her history and physical exam is associated with which of the following? A. Is A correct? Is her history and physical associated with increased risk of functional decline?
No.
Anyone else? So what does she have in favor that can put her at increased risk of functional decline? One, her BMI is 30, is above 30, right? And two, she has significant arthritis, right? Three, she has micronutrient deficiency, right? So I would say yes to this one, okay? What about B? Is she at increased risk for using healthcare resources?
Yes.
Yes.
Yes, right? All these underlying medical problems, yes. She needs to see her doctor and she may need physical therapy and she needs some dietary and physical and maybe some PT and she may need some other stuff, right? So what about increased risk of mortality?
Yeah.
Yeah.
Yeah, right? I mean, sort of by process of elimination, if A and B are correct and there are no other choices, then you know the answer has to be E, right? But she's at increased risk of mortality from cardiovascular disease and other things. And poor diet quality and micronutrient deficiency. Yes, Dr. Lawrence mentioned that she has B12 deficiency. Okay. Any questions or comments? So I hear none. Thank you very much.